Thank you, Emily. It's truly my pleasure to introduce Dr. Joachim Sturmberg, and he can correct my pronunciation there. But as an emergency physician and as a global health practitioner, I've come to the conclusion that we can do much, much better than we have been. From the lack of feedback in what we do to a lack of focusing on what we really want long term to duplications and inefficiencies. I've come to the conclusion in my own work that we need more of a focus on a systems approach to health, public health, medicine, nursing, etc. And as I've tried to learn about systems thinking in health, Dr. Sturmberg's work and publications and advocacy has really come to the forefront. He's truly a global leader in this field. He's a joint chief editor of a forum on systems thinking and complexity on medicine and healthcare in the Journal of Evaluation and Clinical Practice. This is an impressive collection of, I don't even know how many articles now, over 50 articles that deal with the intersection between complexity and health. He's also co-edited a recently published handbook of systems and complexity of health, the first textbook that I'm aware of that addresses this topic. He's currently an adjunct professor in general practice in the Department of General Practice at Newcastle University in Newcastle, Australia. I'm going to put my own personal opinion and plug in here. My opinion is that systems thinking and complexity offers a historical theory and language and approach that we need as we strive to tackle the challenges of healthcare reform and the challenge of inefficiencies and inequities in health. Dr. Sturmberg.
And welcome to everyone this morning. I met briefly a few of you, and I know that you are largely having a student background, which probably is quite a good point to start, because you are not yet indoctrinated in particular ways solidly to follow one line or the other of thinking, and I come back to that a little later. Before I start talking, I want you to talk, because one of the fundamental problems I see is that we have notions of ideas, what health is, and I think we need to clarify that a bit before we really can make meaningful conversations about the health system and health system reform. So what are your ideas of what health is? I don't point fingers. Yes?
I think health is the ability to engage all of life's activities and general feeling of well-being.
That's a very good one. Anyone else? Yes?
I think it would incorporate emotional and social and physical kind of well-being as well, just kind of all aspects of well-being.
Good. Chad?
I'm just going to share the perspective of my training and my practice as an emergency physician. We largely approach health as the absence of disease or treating disease conditions.
Yes?
I'm not saying that's correct.
Well, I think it's an important point you make, because that essentially is, in my observation, how health is treated in the public discourse, and particularly in the discourse at the funder and policy level. And I think the points you made about health are really quite pertinent and lacking. And I want to preempt that what I'm talking about is essentially sharing my journey into this. I don't claim that what I'm saying is a gospel. I leave that to someone else. One of the things is, this is a model that I drew on the back of an envelope when I had to deal with an irate student who said to me, it's all very nice what you're doing here, I'm not interested, tell me what I need to know for the exams, and that's all I want you to do. And I said to them, that's quite fine. You can read about that, because what you need to know for the exams is represented on the physical side of health. But what you can't read in a book and what you need to experience are the other aspects of what your patients present to you with. It's on the social side, how you interact with your friends, your family, on your psychological side, on your mental well-being. And then there's a part of it that is lacking completely in my view, the so-called semiotic or sense-making notion. You have to make sense out of what you see and experience with you. And then notions of spirituality, justice, come into that. And I've coined it to stay in the same language, the somato-psychosociosemiotic model of health. It's a bit of a mouthful, but it certainly gets away from what Chad alluded to, that we are trained on the top corner only at large. Is it important is always a question. And in my view, yes it is, because there is something between the objective and the subjective in health that makes a difference. Those who are medically trained would say this is a really sick person, the heart function in this person limits everything he can do. But he says, I just happen to have a heart attack, I'm getting on with life. He has a supportive social environment, he has an optimistic outlook on the world, and these physical limitations are not the real thing for him. Whereas you can have someone who also had a heart attack but didn't sustain any lasting damage to his heart, who just comes up with the idea of, because I had a heart attack, I now can't do a thing. This person is experiencing his illness in a way that is influenced much stronger by the emotional and the sense-making domains. One of the things that I point out to you who are working in patient care, you can use this model, in my view, as a diagnostic as well as a therapeutic tool. Diagnostic in the way, if you look at the right diagram, where are the core issues to the patient, which in this particular case would be the emotional and the understanding bits. But it also tells you that to move the patient back to a more balanced state, it's not the somatic thing that caused it in the first instance that matters. It is the other bits to pull him back. If you view that sort of, you have rubber bands from each corner and the person is in the center, you can move it around in any which way you want to represent a particular combination that really describe the state of health of this particular person. And this is what I've done as trying to illustrate that. If you do a time course, you would see that you can plot day by day where the patient visually is representing their health. And you then end up with a system dynamics understanding of health. Oh, we lost something. We had a bit of a problem. I have to click frequently to insert it 100 blank slides when I tried to change the order. This is stupid. Let me see. We want. Why is it? Okay, here we are. So if you plot the time points on the same plane, you will get what we call a trajectory, or in technical terms, you get the attractor of the system of a person. And someone like you, I make the assumption, who generally would say I'm in good health, but you know that sometimes you wake up and you say it's a lousy day, or you have slept with a crooked neck and you have a bit of a pain in the neck. But in general terms, this would not affect your health in overall terms. And you get a trajectory around the center of balance of health in that quite narrow way. Whereas when you have the flu, or if you break your arm, you clearly have, for that point in time, an acute physical reason for not being so well, and your trajectory temporarily ends up at the more biological aspect of your overall health. For someone who has a chronic condition, who has, for argument's sake, rheumatoid arthritis, their physical problems will be there all the time, but not necessarily to the point that it sits there only at that phase. But when things go wrong, the effects are much more dramatic. So you may want to go to theater, but because you have a flare-up, you can't take part in the social activities that you're normally engaged in, or you find it just too hard coping with it. Then sort of the semiotic, the sense-making domain may be the more prominent part of your health experience at that point in time. And then we have patients that we could call somatizers, that have no particular biological reason for ill health, but feel that they have ill health, and they have then phases where they are really complaining badly, and then they have other phases where they are feeling a bit better. And they have sort of a strange attractor type arrangement where at times they put the physical issues very much in the forefront, and they have times where they're more complaining about their experience as being bad without having necessarily significant physical symptoms. So I think, from my perspective, thinking about health as being made up of your biological, your social, your emotional, and your cognitive understandings is quite a useful way of engaging with the patient in front of you. And this kind of understanding, as you will see in a moment, will have implications on how we view the healthcare system and healthcare reform. If you look at it from a slightly different perspective, we all have our own health trajectory in the end. And luckily, if you look at the top part for the moment, most of us are healthy for a long time and then have a short period of illness, and then our demise will be there. And what I've done here is to look at the functional capacity on the one axis and entropy as a measure of how your overall function is on the other. And you find that when you have high functional capacity, you have low entropy, and vice versa. When your functional capacity goes down, your entropy builds up. And in a sense, it said we die an entropic death. We get so disordered in our overall function that it's not compatible with life anymore. If you look at the blue line on the top, you see that you can have a trajectory where you have sort of episodes of poor health, where something happens to you and you do recover. But we know that people who have a significant health issue, you do not recover back to exactly the state you were before. You always sort of have a little bit of a loss. If you have several of these episodes, then you will end up lower and lower, and at one point in time you have an episode where you crash through the threshold, and then it's not compatible with life and you pass on. And the red line represents sort of the chronic slow decline in health. If you look at it from the reverse, and that's then the provider perspective, or you end up that you actually need different levels of support to deal with the individual needs of the patient. And you see when you are in good health in the black line, there's only a short period of time where you need more support to keep going. If you have on the red line chronic disease, you see that you end up having ongoing needs for support to keep going. This is a slide that I think every politician should take note of. This is plotting what Kerr White has done over 40 years ago. Now he had a look at the community health experience. The way they did it, they handed out diaries for a month at a time to patients living in the community. And then these people were asked to record their health experience and their health services use. And what came out of it is that most of us are healthy most of the time, or at least healthy enough not to need health care. There is a group that need health care, but they just need a primary care physician who has a look and an explanation, and then things are fine. There's a smaller group that needs some technical intervention. So if you think about it, you have cataracts. It's really nothing wrong with your eyes per se. You just need the cataract removed and then you can see again. Or you have a broken leg, you get a plaster and you are fine. Or you need a gastroscopy because you have bleeding ulcers in the stomach. That type of short-term specific intervention. And then another group of people has the need of the tertiary hospital. If you look at it, who knows what kind of a distribution that curve represents? That's a Pareto distribution, or the 80-20 split. And it works out that Kerr White already demonstrated it over 40 years ago, but he never put it in these terms, that this actually follows a Pareto distribution. It's the 80-20 split. 80% of us are healthy most of the time, leaves you with 20%, 16% are fixed by the primary care physician, 3.2% are fixed by the partialist approach to the specific problem, 0.8% need multidisciplinary care in a tertiary hospital. Who sees a problem here? What's the problem?
All of our money is spent on the small percentage of people who get tertiary care.
That's one. And what's the other? Think about what place you're in at the moment. You're in a university. Where do we teach our students? On the 0.8%. Do they have an idea what it really means to be healthy or to be ill? I leave the answer to you. Oop. A corollary out of that, in my view, is that we need to ask ourselves, what is the role of health professionals? And I specifically use the term health professional because I think it's not an issue of doctor or nurse or physiotherapist or whatever. If you look at health, illness, and dis-ease, which is really the term that disease means, describes the subjective experience of the patient. And we have developed only really since the 1850s with Koch and then with Röntgen in being able to demonstrate the physical representations of what people experienced, the pathology underlying the issues. And I put the doctor there. I think it's important to see the split between the experiential part of illness and the biological part of illness. And the doctor at large, or the health professionals at large, are the brokers of understanding and knowledge between the interplay of the subjective and the objective. If we move forward and leading to what in the end we are wanting to talk about, how to look at the health system more broadly. Anais Nin said, we don't the world, we don't see the world as it is, we see the world as we are. And this is a representation of it, which is from work by Yena Bayan at Nexi in Boston, that there is a relationship between complexity or the fineness of what you look at and the context. And if you look very narrowly, you see high complexity. If you look broadly, you lose that and you see more of the context. And that's represented in the two narrow graphs. If you look at the middle one where it says complex, a lot of it is really happening somewhere in between. And just to illustrate that, if you describe a person, and the important thing is that you look at what you want to describe. If you describe the person in panel 1, you see lots of detail of the person. You have a fine grain. If you put him into a group photo, you see less of the person, but you see more where he is. If you put him in front of a landscape, then you see all of the context, but very little about the person. And I've translated that notion into thinking about the way we approach medicine. The whole kind of the health profession operates on a spectrum from looking at the very narrow, the biomics, the genomics, or you can look at the other end, what Chad is largely interested in, the world health, the population health perspective on the other. And there are lots of foci in between. I have on this slide only represented 3 of them. If you are a basic scientist, you're interested in the genes and in the proteins. If you are working at WHO, you are really much more interested in the global aspects. The middle represents me. I'm a family physician. I'm dealing with the individual person. What becomes important is that in system terms, every system is always bounded and is usually part of a bigger system and contains smaller systems. And the relationship that that a system can have is always only with one level up and one level down. So in that sense, in the middle, if I'm dealing with a person, I do understand a bit of the underlying biological phenomena, and I understand a bit about the social context. And if we look at that in terms of how health is practiced at the moment, there is a subtle but important distinction between a disease focus and a patient focus. If you are, in this case, a cardiologist, you're much more interested in the heart, and you have a relationship to the patient because that is what brings the heart there, but your basic understanding is largely about it has coronary arteries, it has valves, and it does this and that. So compare that to the same person being viewed from a primary care physician's perspective. It's not ignoring one in favor of another. These things are all happening together at the same time. It's just a question, what is the most appropriate focus that a person needs at a particular given time? If you have an acute heart attack, by all means, you need all the skills that a cardiologist has to offer. But when it comes to following up the patient after he has recuperated, the cardiologist really has very little to offer until something goes wrong again. So keep that in mind. If you want to understand complex adaptive systems, you need to really have a model in mind that allows you to make sense out of this rather more difficult to comprehend concept. And the vortex is a classical example of how a complex adaptive system functions. You're all still young, you still remember your kiddies' day. You were sitting in the bathtub. Mom said, come out. You said no. Mom came in again and said, come out, and you said no. And the third or fourth or fifth time, depending on the patience of your mother, she pulled the plug. What did you observe? Why suddenly did you see a vortex emerging? Because the plug hole being open creates the vortex. It is the focus you need for the vortex to emerge. If you look at it then from a more scientific basis, you have the terms I listed there. There's nonlinearity, there's self-organization, emergence, coevolution, self-similarity. All of these things describe the scientific principles behind what you see over there. There's another thing to stick with your experience as a child. You didn't want to get out. What did you do? Put your hand over the plug hole, didn't you? What happened? The vortex went, only to re-emerge when your mum pulled the hand away to let the water out, or pulled you out of the bus, one or the other. And the same thing occurred again. It's self-emergence. But you need to have the attractor being the plug hole. If your mother was really patient and said he or she will come out when the water is out, you often started to play with the vortex. While you played with it, what happened? The whole thing got distorted in many different ways. When you stopped with it, what happened then? It just came back to what it used to be. That describes all the properties, all the things you need to understand about complex adaptive systems, that model. That there are lots of things that are interconnected, and it only can happen if there is an attractor. And what I've drawn here is the health system within this vortex metaphor. In a sense, you put the plug hole, you put the patient and his health. Within a vortex, you theoretically can say there are different levels, and it works quite nicely. You have then the level above where the individual health interaction occurs. You have a level above there that represents your local healthcare environment, your local community, and then you have at the top the political agendas, the political system with its various agents. And if you look at it, you can describe particular agents in each of these systems that have a particular focus and that can be described by particular agendas. But the important thing is, in a vortex, everything belongs to the vortex. So it's not that someone in policy can say, no, do this and it will work. That's just not the way it is. And in fact, this is an analysis of my healthcare system. If you start at the top, you see that the health department is just one segment. It's not connected well with anything else in the policy domain. And if you look at the health department itself, you actually see that they are fragmented and siloized in different agendas, and in fact they're fighting amongst each other like cats and dogs about who get the lion's share of the resources that are there. If you look at the level down, you have the hospital environment. If you look one level below, you have the local health provision environment. You have the patient at the bottom. And what you see is that this fragmented system is driven by budgets, by money. And in many ways, a system can only produce what the system is designed to produce. And what it is designed to produce is reflected in the attractor. So if money is always the issue, you will get only a system that will get money, either in terms of payers having to pay or providers being paid. In one way, the discordance occurs at the interface at the local level, where the providers are forced to deal with money, but where the people that come to them are coming with their health experience. That's the representation of the yin-yang over there. Because in the end we want to talk about health system reform. If you have that clash at that level, it's not rocket science to say that is where you have to resolve it. Otherwise, we continue doing more of the same. What I'm proposing is that if you put the patient and the patient needs at the center of the healthcare system, it's not an issue that the people in the system are the problem. It's the instructions given to the people in the system that need to be realigned. Because it is a self-emergent system, if they know what to do, if they can focus on the attractor, then they will do the right things because they know how to do the right things in their particular context. So if the needs of the patients are there, the interactions that are happening within each level will be harmonized in meeting these needs. And Chet just mentioned a little earlier that he was working with Dr. Curtis, who was a director of the Mayo Clinic. I visited the Mayo Clinic. They function for over 120 years now on the one simple attractor: the needs of the patient come first. They use that to make business decisions, not only medical decisions. So having an attractor that is well known to everyone working in the environment is absolutely core. And that's one thing that I think funders and politicians should take note of. At this point, I want to open it up to feedback from you, and also hearing about ideas you have in terms of taking what I said as a basis for discussion. How would you work to achieve a better health systems design? And I think it's particularly pertinent to the audience here because you are in the state of flux big time, and you see different perspectives, and you are members of the health interface, because most of us, unfortunately, at one point in time or not, have to make contact with the health system, what your experiences are. So if I hand it over to you. We have a microphone for those in the back.
So any comments or questions?
When starting to look at kind of health systems redesign, is the starting point to find, you know, an attractor that people agree on and can focus on? Do you start from there and then kind of have everyone kind of work together to reach that, or where do you start? Where do you begin?
Ask your colleagues. Where would you start? Taking up Fred's comments.
I think one of the biggest things is identifying the needs of the people, but I think it's easy to say, okay, this person has this need, or that's what their apparent need is. You know, like when service responses, people give them things, but it looks like they have a need when it really doesn't benefit them much. So I think the biggest thing is going to the people and just kind of having to see really what people want. Because a lot of people really do want true health. There are a lot of people, which is sad, but they just want to get fixed up. They just want the simple solution as well. So I think there's a balance that you have to find.
Yep. Come on, don't be shy. I don't bite.
I'll tell you, I think when you were looking to redesign some health systems, of course, looking at the structure of the system itself, I think is large group of people and what particular needs they have, and kind of start there and then drill down to the individual person. I think that informs us.
Can you give me an example of how you see that happening, or what you are thinking of?
Well, I'm thinking of like heart disease, which is a huge problem in our country. And perhaps what we need to do is look at the structure that is perfectly designed to create heart disease and make changes
Yes.
in that.
How successful do you think you will be with that?
Well, we've been trying for years and not yet very successful.
Okay. Sounds like Australia.
Talk about the vortex focus on the needs of the patient versus using health as the driver for administrative, business, whatever decisions. And you kind of alluded to that being the driver for health system reform, like using health, the needs of people, as the driver or as the center of the vortex. And in principle, I agree with that. I think that's fantastic. I don't know how you remain financially solvent when you do that. Healthcare in the United States is still a semi-capitalist enterprise where you have to pay in to get the product. It's sort of non-capitalist because you're kind of forced to make decisions with your local provider or whatever. But I don't see how you could have a focus just on health and not suck funds out of other pressing needs of the country. Does that make sense? How do you use health as the driver when health is a bottomless pit and will always suck in more resources?
Okay, let's look at what your country is doing at the moment. Why do you have healthcare reform? Why do you call it the Affordable Care Act? Because at the moment, the system itself is sucking up so much money that governments and others are seeing the light at the end of the tunnel. This bankrupts us, and it bankrupts us very quickly. It's an exponential curve. It's a Pareto distribution. When you are at that steep end, the next point is so much steeper that it doesn't fit on the graph anymore. So if you take that and try to answer your question, is it really a question of the system sucking in, changing to a patient focus, meaning that it becomes more bottomless? If you think about the Pareto distribution of health in the community, isn't that a point for optimism? Or I go one step further to call it the exuberance. Okay. You are young, you want to reform your system. That when you are as old as I am and need it, you still can get it. What do you do? Yes?
I think I kind of agree with what Fred was saying, his idea of now you have to find some new. I guess I kind of agree with Fred that you kind of need some new focus for that vortex, where on the family level, the individual level, maybe they want better healthcare, better overall health. On a policy level or a government level, they want to spend less money, and just kind of figuring out how to change that focus, and then everything else will just vortex into solving that problem, obtaining that focus. It's just an idea, yeah.
Yeah, I think that's where the money is, as I say. I put it to you, health systems reform is that easy. Change the attractor and you are done. I tell you the other part of the story. The hard thing is, how do you change the attractor? I think it's very logical what needs to happen in system dynamic terms. If you know where the problem is, then you can start working on it.
Just to clarify, it sounds like you're saying the healthcare attractor should be individual patient needs, health needs. And I guess my thought is it almost seems like the focus almost needs to take a whole new level completely. And that is when you talk about a patient, you're talking about patients who are traditionally in a, not necessarily a healthcare system, but a disease care system. In other words, you showed that 80-20 graph, and of course, somebody mentioned that the majority of our resources are aimed towards disease care, whereas when you look at it in terms of healthcare, there's multiple determinants of health, and probably the biggest one is education. And so this, the talk about focusing on healthcare and how resources tend to, if you're talking about disease care, yes, it's a bottomless pit. But if you're talking about healthcare, then it becomes a much more balanced approach where healthcare dollars are not just going towards the bottomless pit of disease care, but in a balanced way addressing the true determinants of health. And I guess that's the focus that I would say needs to happen, is that we've had such a long period of time of the industrial medical complex sort of dictating what is health, and we've found that is not only expensive, but it's not effective in truly bringing about health. And so a true focus on health rather than disease will provide a much more balanced expenditure of resources.
I couldn't agree more. I think it's always difficult to stay true to terminology. You have seen that I put not the patient, but I put health at the center. But health belongs to someone, which is a person. And there's a big debate in the philosophical circles I'm dabbling in to talk about, do we have person-centered care or patient-centered care? A patient is a vulnerable person by definition. That's what patient means, the vulnerable. And in that sense, everyone has a particular responsibility to deal with a vulnerable person, the patient. But because, taking up your point about we need to also have a population view, we are only a patient at the point in time where we feel vulnerable and open up our vulnerability to our health professionals, whoever that is. So think about it more in terms of the person being and the person's needs are in the center. And the non-medical aspects are the ones that are most important. It's, do you have education? Do you have work? Do you have a healthy living environment? Do you have clean water? The Romans already knew it. They said never build close to a swamp, have clean drinking water, and they invented the in-house water closet. Goes back, 2,000 years. So much of this is not really new. Much of it has been forgotten. You wanted to make an extra comment.
In terms of sort of the economic distribution of resources, oftentimes the needs of the patient, of the person and their health may actually necessitate restriction of healthcare expenditures because of the fact that it's part of a system where you spend too much on one component, you're not going to have the resources to address the other components. So in that sense, rationing of resources can definitely be a very important part of a person-centered approach.
I agree with you, on the basis that if the resources are distributed within health care, where it really is needed, too much of our care is generated by the medical industrial complex. Just because I'm a cardiologist and you have presented with a heart complaint, you get an ultrasound, you get a catheter or a CT angiogram, as a matter of fact, that is where it goes wrong. I'm not in favor of abolishing anything of the marvelous things we have developed over the last 50 or 60 years based on what started with essentially Koch and Röntgen, the ability to demonstrate what's going on, and then the developments that came out of it. Where I have problems is that we think about health in anatomical rather than in functional terms. And what you are alluding to very much in my view is that the functional component of health is all these issues of education, public infrastructure and so forth that belong into it. And that comes back to the question asked earlier, is it a bottomless pit? In accounting terms, it becomes a bottomless pit if you look narrow, if you forget the context. If your health policy, or if any policy, would have to have a health impact statement on it to take into account what are the health consequences of building a new road, tearing down a school, ripping up a park to put a parking lot in, not having the issues of the physical environment not conducive to physical activity, then the true health costs, in my view, are quite underestimated with the roughly 20% of GDP that America currently uses for healthcare. I think it's probably more in the order of 50 or 60% of GDP if you take all the other things into account. And I think from a complexity perspective, it would be a nice PhD to do and untangle the hidden costs of the healthcare system. I think there is a very nice example coming from the States too. It's the Somerville project. Has anyone of the public health students heard about it? Somerville is a deprived community north of Boston. And they had really big troubles with their health. And it was a dietitian who started the Somerville project by trying to get better food into the school canteens. And they ended up in sort of a ripple effect. The kids got better food, that got all the junk out of it. They went to their parents, and the parents learned to eat healthier. They went to the community and then have now restaurants that have a label on their Somerville project. And they are booming, and the Macca's and Co. Are suffering. They got their bikeways fixed so that kids can use their bike safely. They rerouted the school buses that kids could walk to a bus stop rather than having been driven to school. So it is just a very simple thing of looking at it in a slightly broader context that can make a change. What I'm trying to get across to you is if you start thinking differently, then you see different possibilities and different opportunities. And I remind you about Anais Nin. It's the world is as we are. In terms of health systems reform, Einstein told us long time ago, you don't solve the problems of today with a solution that created them. Doing more of the same can only produce more of the same. Don't be surprised. I just have this summary slide, which I've taken from one of my papers, where I tried to pull all this together. We have a truly complex problem to solve, or they sometimes call it wicked problems to solve. Wicked problems don't have one solution. Wicked problems have many possible solutions that coexist, that are equally valid, and that are context-driven. Just to remind you, starting from the right, community epidemiology. Most of us are healthy most of the time. if you take the complexity perspective, high complexity means high uncertainty. You live every day with high uncertainty. Most of the time, you don't have anything wrong. It's only when you develop a specific disease that the complexity goes. Disease is loss of complexity. And then when you have a narrow, well-defined entity, it becomes easy to describe it as a disease, and you can have a simple intervention to it. Health promotion, and lots of you work in the public health domain. There is not a simple answer to stopping cardiovascular disease problems. And while we are thinking, as far as I see it from my Australian experience, it's about lowering cholesterol and stopping obesity. That's not getting you anywhere. So you need to think about it in these ways. Think about health from a subjective and an objective perspective. And think about, I think most importantly, you become a patient as a member of your community. Population health, in my view, is nothing else but health of the individual. The collection of us makes a population. And it is some of us that contribute to the disease burden we so often talk about. It's much more important to look at the outside domains of our environments, whether it is a physical environment, the social environment, the educational environment, the work environment, that are influencing how well we do in the long run. Forget about the bits at the bottom for a moment, but you see that as you come down further and further to the person, the more specific the needs and the more specific the interventions are. And as health professionals, we all need to be able to access the different resources in our communities to help to meet the needs of that particular person. From a public health and from a primary care perspective, most of the time it is not a chat in the emergency department when you got into dire straits. Most of the times it's finding more teachers, more social workers, cleaning up the environment to make it safe to be an active participant in the community that can work out the natural features that make health possible, which wasn't the fact that long ago. So I hope that gives you a little bit of an insight and inspires you to look at your studies for the students and at the advocacies roles you have as faculty to foster a discourse that gets us from a disease management system to a true health system that deserves the name. Thank you very much.
Thank you very much, Dr. Sturmberg. I think that was an enlightening and challenging discussion. In my view, discussions like this, while we might disagree about where the vortex is or what the attractor should be, it gets us thinking about, number one, what we really want, because I think there's some agreement, health, efficiency, equity, satisfaction, et cetera, and how we interact as individuals, as professionals, as sectors, as disciplines, et cetera, to impact what we really want. And I think the work that Dr. Sturmberg is doing and is thinking and is moving us towards that type of discussion. Thank you very much. A few final housekeeping notes. As some of you know, Dr. Sturmberg is going to be here in Utah for the rest of the day. We're going to spend 20 minutes or so in 5 minutes just having a very informal discussion about the global state of complexity in health. So what networks are out there, what's going on, what might we see in the future. So you're welcome to stick around for that. And then we'll be heading up to the University of Utah, and there'll be a couple lectures and discussions up there, and you're welcome to join us for that as well. Finally, as some of you know, there's a systems thinking and health discussion group here on campus. You can get some of these handouts. This is funded through the Doris Duke Charitable Foundation. We have weekly meetings on Thursday at 11 a.m. Thank you very much. Take care.